Okay, well, thank you everybody for joining us today. We're going to be talking about a very interesting. I'm Joe Antos with the American Enterprise Institute, and we're going to be talking today about a very interesting study conducted by our main speaker, Marge Ginsburg, who heads the Center for Healthcare Decisions. And the interesting part of this study is that outside of Washington, American citizens understand something about limitations and scarcity. They actually understand that if you want to get something more in a program, that you might have to give something up. Now, unfortunately, this is not a concept well known in Washington, so I know that this is going to be quite a revelation to, well, probably not the people in this room, but if only Congress would listen. Anyway, let me introduce the speakers. And as I mentioned, Marge Ginsburg is the founding director of the Center for Healthcare Decisions. And there were copies of the executive summary of the report. And you can also find the report, the full report and the executive summary online. She's going to lead us off. And then we will have a discussion with three of my favorite people: Bob Moffett from the Heritage Foundation, and he is senior fellow. I'm a little confused because I don't know what your new title is, but I'm reading senior fellow in the Center for Health Policy Studies. That doesn't sound pretty good. Yeah, exactly. And as everyone here knows, Bob is a longtime veteran of health policy, spent some time in HHS, successfully reforming that agency while he was there. Times have changed, however, Bob. Then we have Dr. Kavita Patel, who is the Managing Director for Clinical Transformation Delivery at the Engelberg Center for Healthcare Reform at the Brookings Institution. It doesn't correlate. It's always good to have a long title. But as Kavita also is, well, she's also a veteran. She's a young person, but she's a veteran. And then finally, John Rother is the president and CEO of the National Coalition on Healthcare. And we all know John from his very, very long experience with AARP, and now he has his new organization. So we're going to start with Marge, and then the panel will take off, and then at the end we'll give everyone in this room a chance to ask a question, and we'll see if we give you any answers. So Marge, take it away.
I think that's right. Let me know if you can't hear me. Okay, thank you all for joining us, and thank you AEI and Brookings Institution for sponsoring this event today. I'm very pleased to be here and to present the findings of this project. I know you have the executive summary that was provided for you out front. It's extremely difficult to even write an executive summary on a project that encompasses so many different concepts. So let me nag you into going onto our website and reading the 40-page report. You will learn a lot more about it, the project and the findings if you do that. So thank you. I think I've got about 30 minutes, and so the content for my time, I'm going to give you a very brief overview of our organization and about public deliberation, which is the methods we use to understand what's important to the public. I'm going to describe the use of the chat process for the deliberative method we used for MedChat. And then I am going to give you some of the select results of MedChat. It's going to be select, it's going to be small, it won't be everything, but I think we're going to touch on some of the major findings. And then I'm going to talk briefly about the now what. So what? We've done this, what are you going to do next? So just a word about our organization. Center for Healthcare Decisions was started 20 years ago with the goal of really understanding how the public responds to complex health policy issues. There are many ways to capture the voices of the public, and you're all familiar with them. Town hall meetings, surveys, even focus groups, but generally what they give you are people's, their opinions, what they like, what they don't like, what they want, what they don't want. But generally they don't go much deeper than that. And in the field of healthcare policy that's extremely, not just complex, but where there's just, it's rife with pros and cons of everything you look at, that if you really want an informed public view, you might have to go a little bit deeper than simply understanding people's opinions. And that's what we do, and that's what we've been doing for 20 years. So public deliberation itself, I'm just a brief overview of kind of what the elements are that makes it special. So the main difference is that we try to focus on what is the problem that needs to be resolved and what are the options for doing that. How do we use public input to actually move forward on health policy options that are now being considered? It could be considered at the company level, at community, state, national level. It can be very small or it could be very large. But the fact is engaging the public in ways that you can understand what is most important to people when trade-offs are inherent. So first issue is that there has to be an issue that involves competing priorities or policies. There's more than one strategy that can be pursued, and a very structured discussion process for understanding what people feel is important. Certainly accurate, unbiased facts. We are, if I didn't mention it before, a non-profit, nonpartisan organization, and being nonpartisan is absolutely essential to everything we do, or nobody would pay any attention. There's always going to be alternative approaches to how we get to answering this question, and diverse perspectives are particularly important. So the idea of deliberating is core, that it has to be in a group setting in some fashion, more than one. People learn not only from getting the chance to talk out loud about the things that are important to them, but hearing others, particularly others that look like them. That expands their views about, in fact, what is the right thing we should do. Detailed reason giving is core. Capturing quantitative data is important, but unless you actually understand why people hold the views they do and why they are willing to make trade-offs between one option and another, then you haven't really understood what those public values are that are key to their thinking. And I think it goes without saying, facilitation has to be absolutely neutral. So at the end of the day, you're looking at how people address some of the common tensions that exist in healthcare. And some of these tensions are known to you already. These are tensions like choice versus affordability, physician authority and medical evidence, patient autonomy and safety, personal responsibility and individual freedom. These are all values inherent in how we think about healthcare, and all of them can conflict at one way or the other when looking at healthcare policy. So one question that often comes to me is the general public actually capable of looking at policy issues from a societal perspective? Can they take off their patient hat and put on what I call their citizen hat? We all have reason to be somewhat skeptical. We're a very individualistic society. People think about healthcare very personally. It is personal. Nothing is more personal than your health and well-being and longevity of you and your family members. So how do you get people to move from thinking about solely in terms of what's in my best interest to what would be in the best interest of all of us? We also all know that all health insurance is communal. So we have, on the one hand, this need for maximizing our personal well-being, and on the other hand, having to work within an environment where, in fact, we all must share the same benefits package. So the answer to the question, can the public take a societal perspective? I've been doing this for about 23 years, and if the public could not do this, I would have moved on to environmental warming, an easier topic. So yes, they can do that. So why MedChat? Why did we decide to take on this project? I mean, that's kind of obvious. The spotlight has been on Medicare for several years. Certainly it's Fiscal demise has been talked about a lot and put to rest momentarily by the CBO, who said it's not going to fail in the next few years after all. But regardless, discussions are happening in Washington about Medicare and what to do about the future of Medicare for a long time. It just seemed an opportune time to take this topic to the general public. I want to talk a second then about chat, which is the tool we used for conducting this. And the reason I'm going into all this detail about the process is that you simply cannot appreciate, I don't think you can appreciate the results unless you understand how they got there. So chat is, in fact, a computer program. It's a simulation program for designing many things, but in particular for designing a health plan. It was developed by two physician ethicists, Susan Gould at the University of Michigan and Marion Danis at the National Institutes of Health. They designed this in 1999. And as all good bioethicists, they well knew that we are always going to be able to do more things in healthcare than we can afford, and that we need to figure out a way to allocate our resources in a fair way. They also knew that the public knows nothing about health insurance, and that in fact health insurance is an exceedingly complex and very, very boring topic. So if you want to have a legitimate public voice in what happens in healthcare, then you better figure out a way to make this interesting, engaging, and informative in a way that helps provide some direction. So they developed it for those purposes. It's a very highly structured process that takes 2 to 3 hours. The Medicare chat project took 3 because it was particularly complex. And now they're actually using chat for things other than priority setting in healthcare, which is encouraging. There are many other ways you can use it. And the other interesting thing is they moved from a paper version to laptops, and just this past year, one can now do chat on tablets through cloud technology, so all of the data can be captured through the clouds and you don't have to download, do all that sort of work. So let me move on then to what the chat board looked like that we developed for the MedChat project. Rather than create benefits categories that you're all familiar with that are very typical, your provider, primary care, specialty care, hospital, drugs, DME, blah, 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 blah. What normally constitutes a benefits package. We decided to focus the choices as much as possible around healthcare needs, not healthcare services. So we have more creative categories like early chronic, complex chronic, catastrophic, routine care, final phase, and then of course we have other topics that are more specific, mental health, an issue about what level of provider choice you want, should the premiums be increased. So there are a number of ways in which we tried to capture that. There are, as you can see, there are layers to this chart, and there are actually 3 tiers. So you've got 12 categories to choose from, and within each category, you have either 1 tier, 2 tiers, or 3 tiers. The tiers represent benefits design, which is what are the criteria or the qualifications or the components that are inherent in that design. So the higher the tier, the better the benefit, but the more markers it costs you. This pie chart, those little white spaces represent markers, and that represents what the cost is. There are 130 marker spaces, and as you'll see in a second, people have 100 markers to use in doing this. So where do priorities lie? So what we tried to do in designing this is to try to bring in as much as possible some of the contemporary health policy conundrums that are being dealt with. So this isn't just a simple matter of you can have a high copay and a low copay. We folded in issues like high value versus low value care and whether low value care should be covered. Should we continue with unrestricted provider choice? By the way, this model was set up so what they were doing was deciding whether they wanted to redesign traditional Medicare. So we did not get into Medicare Advantage. We didn't even get into Part D. All of that is folded in here, but this is really focused on traditional Medicare. So should limits be placed on low-value care? Should penalties and awards be used to promote compliance with your medical regimen? What other services should Medicare cover? Should patients be required to use hospice and not a lot of extraordinary life-sustaining treatments that often usually is ineffective, and should higher income patients pay more. So this is a screenshot of what the actual chat model looks like. So you had a close-up of the pie chart. Now you can see down at the bottom, these are the 100 markers they have to spend. And people are told those 100 markers represent the current amount that Medicare now pays per beneficiary. So this was not a rationing project. We weren't taking any money away from anybody, but it was their option to put the markers where they wanted. Every time a current tier was shown, a current benefit, that we indicated that it was current. Because most people, even those on Medicare, have no idea what in fact Medicare covers. So we had to make sure that they understood, if they were picking a particular category with the tier, that that particular tier was now what Medicare covered. If they went higher, it was going to be better. It's going to cost them more money if they went lower. If they took their 100 markers and put it entirely on every tier that said current, they would have spent all their markers, and they would have left with exactly the same health plan. So their task, we asked people, was that should Medicare change for the future? You know, this is the program we've had for a while. Would you want to, for yourself and others, change it to look differently than it does now? I think I've covered everything on that. Oh, let me just point out on the far right there, you can't read it, but the complex chronic is up. And what happens is that people click on one of the wedges, and then on the right, the definition of that category comes up, so they know exactly what we're talking about. And then they scroll their mouse over the tiers on the right, and it tells them what they're getting in that tier, and it tells them how many markers it will cost. Once they decide they want, say, tier 3 of complex chronic, they click it, and it moves all the markers from the pool, and it fills in all the white spaces. So they're actually actively moving their markers around, and then when they realize they've made some horrible mistakes and were way too greedy, they can go back and unclick, bring markers back to the pool, and reallocate them to others. So it's a very, very active process for getting there. There are 4 rounds that they do to create the best plan. The first round, everyone makes a decision for themselves. One of the things we've learned about understanding people's ability to be social decision makers is they have to start by thinking about themselves. If you don't let them create it for themselves, you know, you're going to be living with that perspective here on out. But once they get a chance to say, what would I want? Then people are more prepared to move on to say, okay, now what should we do for the whole country? So this is their independence. Round 2, they work in groups of 2 or 3, and now the assignment is they do have to create the Medicare plan for the country. And now, for the first time, they're actually hearing the views and perspectives and experiences of others. So they have to duke it out until they can come up with a plan that the 3 of them can agree on. Round 3, which is, to me, one of the most critical rounds, is the whole group, usually about 12 people, have to make a decision together on what it's going to look like. And this is where the facilitator is particularly active in probing and challenging and getting them to think, making sure that they're thinking of all possible ways, downsides and upsides for their choices. This round is audio recorded and transcribed, and this was what forms the basis for our qualitative findings. So when you read the full report, because you're not going to find it in the executive summary, you'll see a lot of direct quotes, and you'll see a lot of the reason giving, and this all comes from round 3 when they have to justify why something is more important than something else. Round 4, they go back to their own computer, and now this is their final decision. They've heard every possible argument they're going to hear for one thing or another. They're making a decision for the country, not for themselves, but nobody's looking over their shoulder. The round 4 data to us is the most important to collect, and that is the basis for all of our findings, is what do individuals choose at the very end. These were our project partners for this project. It was a large project. It lasted a little over a year. Leading Age California, a nonprofit organization that oversees senior services and long-term care services in the state, was our lead partner, and all these other organizations contributed their time. They were trained as facilitators. They organized meetings. They convened meetings. recruited people, and they really helped give the project the expanse that we were able to get. The project was primarily funded within our own organization, but we are deeply grateful for several other organizations who helped contribute. Certain Leading Age was one of them. Blue Shield of California, Dignity Health, and Sutter Health also contributed funds to help make this project most effective. Okay, and so now I'm going to get to the select results. And I'm going to start with the reductions in coverage. Let me start by saying, of the 12 categories, there were only 2 where the majority of people in round 4 kept the current coverage. Every other category, they went higher or lower. So that in itself tells you something about people's interest in doing something a little bit different than what they've got now. So restricting provider choice, reducing coverage of low-value medical care, and changing coverage of end-of-life care, I'm going to talk about in just a minute. Okay, so the first one is the provider category. And this one is probably self-evident. Tier 3, the highest tier, is current, and that's, of course, remember, this is original Medicare. You can go to any physician and any hospital you want at any time as long as they take Medicare. And then they could save money by having more restrictions. They got all the way down to Tier 1. They're basically saving 9 markers by insisting that everybody enroll into a provider network. So all of their providers within that net, didn't have to be a small network, could be a large network, but it was a network. Tier 2 was a compromise. You were in a network, but with the discretion of your primary care provider, they could refer you outside the network if there was a valid reason for doing so. You'll notice on the far right, we indicate the number of markers, because the number of markers that are allocated are really key to helping people think deeply about how wedded they are to certain things. And I don't think I mentioned before, the marker values for all of the tiers were calculated by Milliman. They've been our consultant on chat projects for about 10 years, and they were the ones that helped figure out what is the cost of this category and tier representative to the rest of Medicare spending. So this is as close to being realistic to actual costs as we could get. So as you can see, 1 marker Tier 1, 5 for Tier 2, and 10 markers for Tier 3. So what did our 781 people do? As you can see, the vast majority went with what we call the network with wiggle room. It's probably self-explanatory why they did, and some people would argue, and we even present in the report, that this is California. I mean, we live and breathe the network model in California. You know, would you see this same level of willingness to go to abandon complete freedom of choice, which is a hallmark of original Medicare, in order to use those markers for somewhere else? So don't know yet whether this would be elsewhere. And, you know, it's not as if nobody wanted unrestricted choice. Certainly many, many people did. But clearly they were ready to set some limits on that. Complex chronic was the other big one, because this was the category that most explicitly dealt with the issue of high-value, low-value care. We actually had 4 categories that dealt with the concept of balancing effectiveness with cost, but this was the one that was most explicit. And let me sort of give you the definition. Complex chronic refers to those whose chronic illness, heart disease, diabetes, etc., are more difficult to manage. And while the tiers for providers were characterized in ways familiar to most people, the freedom to choose, complex chronic tiers are characterized by whether Medicare should continue to cover low-value care, which we define as treatments that are unlikely to work, whose benefits are small, or whether there's another treatment just as beneficial but less expensive. So let me show you the results here. So this was a major, and complex chronic was a very big category. Together, it represented 33 of the 130 markers on the board. So it was a very big category. And Tier 3, of course, represented Medicare, the current benefit, where all services are covered, low value and high value, if the physician approves it and if FDA has approved it. There's really no distinction on that. And of course, Tier 1 is that there is no coverage for low-value care. Tier 2 is a compromise. We generally like to put in something that's a compromise to give people some way out. But this was pretty surprising, even to me, who's done this a while, that 88% felt that we really should get a handle on low-value care, and we should not be spending our money, or at least doing so with greater care than we are doing now. And final phase was the other one that was particularly noteworthy. And the description of this, because I know you don't have it in your executive summary, is this category was a description of those with incurable terminal conditions who are growing more frail, frequent hospitalization. So generally characterized as the last year of life, and the trajectory of their health status starts to become clear. They are not necessarily actively dying. So Tier 1 offers them palliative care and hospice, but that's all. No more Hail Mary passes of chemo treatments that probably are not likely to work, or heart surgery that's inevitably going to fail. No dying in the ICU. All the services are provided to help support the person and give them the most comfortable quality of life possible. Tier 2 is a compromise. If patients or families want what we call the last-ditch treatment, the Hail Mary pass, that's their decision, but it would not be covered dying in the ICU. They would have to go into hospice. Tier 3, of course, is current. And you can see the price, or the marker differences for that. So this one was a surprise to me, because most of the time, the public likes to find a compromise. They like the middle ground if they can afford it. 65% said Tier 1. And this was pretty universal. We do have, obviously, we've done a lot of demographic breakdowns, and later, if you want, I can talk about those. But, and this was the topic where there was the most discussion and yet the most unanimity of viewpoints. That we do too much at the end of life, that families often don't know what they're at, they don't make rational decisions about whether to continue treatment or not, that doctors are offering, if not foisting, treatments on people that they shouldn't be, and that it's only to the detriment of patients and families. We had, obviously, some people who felt strongly to the contrary, but it was rare that they were able to persuade anybody else, their view. This one was also interesting in that it was the only category in round 3, where the whole table have to decide, where no single group picked Tier 3. The only category where no group did not pick a particular tier. And as it shows here, only 3% of folks in the last round actually picked Tier 3. Okay, let me talk briefly about increases in coverage. So probably to the surprise of no one, they did want 1 year of long-term care. This is genuine long-term care coverage, and I'll show that in just a second. Also wanted to add dental, vision, hearing, and transportation for medical appointments. They wanted to augment the mental health services to some degree. Those were pretty low-value categories that didn't take a whole lot of markers, but they worked really hard to make sure that they got in. The other thing that was very interesting, one thing that we offered them, I said this wasn't a rationing project, but we gave them the option to use some of their existing 100 markers to extend the life of Medicare. So in other words, if they were willing to contribute 8 markers of their 100, then Medicare would be able to extend for another 50 years without worry. 11 markers would get them 75 years. But basically what they're saying is they're reducing the size of the pie chart for current users and all future users. The pie chart would be smaller, but Medicare solvency would be clear. I don't have the figure directly in front of me, but I think it's 77% wanted to extend the life of Medicare, and most important, we're willing to contribute their markers to do that. A lot of discussion, and by the way, the folks who participated in this, which I didn't mention, was a broad, they were existing seniors, They were younger people. About 2/3 of the people were under the age of 65. Thank you. Thank you. 85% were willing to reduce Medicare spending on current. Yeah, it's actually in your summary report. Thanks. So let's just talk a second then about the long-term care benefits. So Tier 1 was current. Most of you, if you know something about Medicare, you'll know that the long-term care benefit isn't really long-term care. It's post-hospital acute rehab. So they had Tier 2 included 1 year of genuine long-term coverage. So that means in a home, a community setting, but people who need services the way we know it and the way Medicare doesn't provide it. And 3 years Tier 3 got you 3 years of long-term care coverage. So these were the results. And of course, the majority picked Tier 2. Most people would have loved to have Tier 3, but they simply couldn't find the markers from any other category that they were willing to spend. So relatively few, 23%, didn't want to support it either because they felt the markers were better used on another category, or many of them felt that this really wasn't the role of Medicare, that it wasn't intended. It's supposed to be for medical services. It's not supposed to be for all the social needs that people have at the end of life. Okay, so now what? So I'm not answering these questions. I'm only posing them. But one of the things, of course, we're most interested in is how do these findings relate to current policy interests and other research. I will make a brief reference. I'm sure we'll hear from our responders to the IOM report that just came out called Dying in America, where there's a very strong linkage to what that report is and what our folks said here. But all of the categories that they talked to, in fact, there really is a trail that can be pursued on what's going on in healthcare reform nationally. Is there a deeper dive into how to reduce low-value care? Very, very big topic, I know, within private insurance. And I think based on the MedChat findings, just touched the surface of people's views about low-value care. And I think this is an area that really requires much deeper deliberation with folks about what does that mean, who does it, how can it be done fairly, how do we know that we're not actually going to be denied something that's going to be of great benefit. Encourage others to replicate MedChat. I shouldn't have put a question mark there. I absolutely believe that this project should be replicated elsewhere. It was done in California, and I know we take the lead on everything, but I suspect some of the findings may be different if you did it in a different state, and I think to make these findings resonate with even more policymakers, it really does need to be done in different locations in California. And the last was just the idea of experiments. So what could be done to actually put into practice, or at least test out some of the concepts here? I make a reference to the TLC option. It's in the full report. And this was an option, I'm not going to take the time to describe it, but Dr. Arnold Milstein had proposed this to me 4 years ago, and we had an extended discussion about how one might do trade-offs between getting extraordinary life-sustaining treatments and instead of that, using those markers, if you will, for long-term services and supports. So I'll leave it at that, and I do hope that you'll read about some of the options on how one meshes the results that we hear to actually form new ideas on how to improve Medicare for the future. Okay?
Thank you very much, Marge. That was fascinating results, and you managed to even get me to understand how that process works. So that was really good. The slides will be available on our website, and I think they're well worth looking at again. And as Marge said, the full report will have a link to that as well. I did want to take exception, though. I mean, health insurance is a fascinating topic. I'm not going to ask for a show of hands about how many people think it's really fun, but I think on this panel, yeah, we're there.
Bob, please. Marge, congratulations, and congratulations to the Center for doing a public service. We have been doing surveys of senior citizens on Medicare as long as I can remember. The surveys, of course, have a historical pattern. Surveys show that Medicare is overwhelmingly popular among senior citizens. Many of them, thank you very much, Kavita, many of them tell us vehemently that they have paid for their benefits. Surveys also show that they actually know very little about the program, how it's structured, how it functions, how much it costs, how much it's projected to cost, but it works just fine. Thank you very much. This, I think, is a breakthrough in a very important area, and that is, instead of just asking broad questions, what the center has done here is to say, okay, fine, if you want X, that means you may have to have less of Y. Our colleague Bob Blendon at Harvard University has done some of the very best work in looking at American public opinion on health policy. And he makes the point, I think, very, very well, that you can have the most attractive healthcare policy proposal imaginable on planet Earth. But the very moment that you talk about the necessary trade-offs that are required to actually put that plan into action, support for almost all of these proposals declines, usually dramatically. And that is kind of the pattern if you look at the history of public polling on Medicare as well. I said this is a breakthrough, and I say it's a breakthrough, but I also want to stress one thing that Marge has already told you, but it's an important point. One is that the survey is, the reason why it's so instructive is because it's so upfront about the limitations of what it's telling us. The first thing, for example, is that the population here we're dealing with is 800 people in California. Now, I know California. I have relatives in California. I know what they're like. And they're wonderful people. They really are. But they're not the kind of people that you would find, for example, deep in the heart of Texas. They're not the kind of folks you would find running around Salt Lake City, Utah, or Greenville, South Carolina. And so I think that's a vitally important point. Our colleague Henry Aaron always makes the point when it comes to healthcare policy, that healthcare policy, especially when you're dealing with the exercise of government authority, is to a large extent shaped. The views on it are shaped by the political culture of the place where people come from. And I think that's obviously the point. So that is an important point. The markers, I think the markers are, as I mentioned to Marge, I think the markers are the best you could possibly do in a kind of a survey like this. And so I don't criticize them. I just simply want to make another observation, is that the markers here are a trade-off between preferences and so on. It's kind of like, I'll trade you 3 blue marbles for 1 red marble, and I don't criticize this. Understand, this is a way of getting at trade-offs. I think going for a deeper dive would put all of this in very clear dollars and cents. And that would mean, what is this going to mean for your Medicare premiums? What is it going to mean for your taxes? What is it going to mean for your co-payments and so on? So I think dollars and cents, I think, concentrate the mind, kind of like public hanging. It's the kind of thing that really gets people thinking about whether they really want to do these things. It's focused on traditional Medicare alone, which means that this survey does not deal at all with the big issues that, in fact, Congress is wrestling with in terms of Medicare reform. The Ryan proposal, the Rivlin-Domenici proposal, and so on. And it doesn't directly address, I think, the real tough questions that must be asked. It raises them. That's what I like about the survey. It raises the questions. Just mentioned just a couple, there's several, but they point out the tough policy questions that would have to be resolved or balanced are preserving patient choice while achieving a common good for all. Okay, that is a huge question. If you decide that you're going to limit my personal freedom over matters that affect my personal life and my health, because of your conception of what is good for other people, you better have a very, very powerful argument to convince me to go along with that and not simply rely upon another regulatory edict from the Healthcare Financing Administration, force or coercion or prohibitions. CMS. Well, it's kind of the same thing. It's a corporate subsidiary, as we call it. Preserving the professional authority of doctors while committing to evidence-based medicine. Now, that's a huge question. I don't know anybody who's actively in favor of quackery, at least actively in favor of it. Professor Marvel, for example. The pursuit of medical treatments that are of no value to them or dismissive of medical evidence. So it's not surprising that 88% of people support value-based coverage. But this comes into the deeper dive. When you say that you favor value-based coverage and payment, the question is, of value to whom exactly? What is the standard of value? Is it the value to the medical profession, to the research community, to CMS, to the medical establishment, the Office of Management Budget? Who? This is a critical question. Obviously, you're saying, well, the patient should make that decision. And in fact, we do actually do that. When you go for a very serious medical procedure, often they will hand you a consent form and ask you to sign a consent form on a matter that may be of life or death consequence. So obviously, we value what people think about that particular medical procedure. You can't say that we value patient consent and then argue at the end of the day that patient consent is of no value. The doctors are under these concerns right now. I think the only thing I would say here is that we do not have the level of sophistication in the determination of the value of services in the medical sciences that we have in many of the physical sciences, okay? Let me just mention a few. For example, atrial fibrillation, the treatment of it, an irregular heartbeat. There are several courses of action. You could do a cardioconversion with electric shock. You can do heart rate control with beta blockers or calcium channel blockers or drug therapies or surgical intervention, which, by the way, can be curative but also carries really significant risks. The point is that medical innovations are constantly changing. Value is therefore, whether something is working or not, is something that is subject to qualification. What I think you don't want to do, and this is my plea, is you don't want to put this in a regulation from CMS at the end of the day. My point is simply we ought not to make a fetish out of evidence-based medicine. I want to just mention a couple more things and I'll shut up. One of the most significant findings that has come out of California is the agreement that we need to control Medicare spending and the growth of Medicare spending. This is a very significant thing. I think it is, politically. You'll recall that President Obama himself has made the point that if we do not reform Medicare, he says gradually, it will not be there for future generations. That's what the president has said. I don't know of any serious political figure, either Democrat or Republican, who does not think we need to control the growth of Medicare spending. That is already happening. There's a debate as to why that is happening, but it is happening, and it has to continue. So that is a very significant finding. I think the need for means testing, this is a very interesting thing. It's another way of saying that we should reduce taxpayer subsidies for rich people. Respondents overwhelmingly support increasing means testing on people who are already means tested now. It's about 5% of the population, people who make $85,000 or more. But here's what I thought was interesting. 20% of them want to start the means testing at $50,000, which, by the way, is a proposal endorsed by Senator Claire McCaskill. Okay, just in case anybody doesn't know. That is roughly the median income of the American family. So that's a pretty significant development. I would like to continue to go down the income scale to $50,000. As for me, I think that's a good way to save money. The decision, by the way, of the overwhelming majority of these people to, and this is, I think, frankly, remarkable, the decision to end traditional Medicare fee-for-service. That's supremely interesting. 82% of the respondents favor specific provider networks rather than the traditional Medicare practice of seeing any doctor you want. In other words, the vast majority of seniors, and at least in this survey coming out of California, want to end Medicare as we know it. Barbara Boxer should be notified immediately. They even go so far as to endorse an updated version of the HMO gatekeeper. You can go outside of the network with the permission of your primary care provider. I just want you to think about this for a second, because you remember back in the late 90s, we had a major debate in this country on HMOs and gatekeepers, and the House passed overwhelmingly a Patient's Bill of Rights legislation, died in the Senate. But nevertheless, there was tremendous public hostility at that time to staff model HMOs, to gatekeepers, to restrictions on your ability to go to a specialist. I remember going to see this wonderful movie with Jack Nicholson, As Good as It Gets, and on screen there was a vituperative, expletive-deleted part of the script that talked about HMOs, and I was in the audience, and the audience exploded into applause. Here, California's saying, no, we're for this kind of thing. I think that politically is a huge, it's a huge change. I think we got to recognize how significant that is. It may also explain, to some extent, the tremendous growth in Medicare Advantage that we've seen over the past few years. From 2010 to now, Marilyn Tavener of HHS just told us you've had a 42% growth in enrollment in Medicare Advantage, where in fact you have basically managed care systems and so on. So anyway, congratulations, Marge. You've made some breakthroughs, I think, in public policy in terms of survey research. I think we need a deeper dive. I think we got to get into dollars and cents and show the real trade-offs. I will say one thing that is totally unsurprising is that they want more benefits. And I'm sure they do. And the long-term care sounds great. I'll just end with this one observation. John Rother is looking at me intensely because he knows what I'm going to say. I'll keep an eye on you too, Rother. Back when Joe Antos and I were campaigning avidly, feverishly, for the adoption of the Medicare Catastrophic Act of 1988 under the Reagan administration, Claude Pepper, you remember him, the chairman of the Pepper Commission, wanted to add on the floor of the House an amendment that would add a long-term care benefit to the Medicare program. The Congressional Budget Office estimated it to be $35 billion annually. That's the cost. That was back in 1988. Those stalwart champions of fiscal conservatism, Henry Waxman of California, and Dan Rostenkowski of Illinois, tight-fisted Dan Rostenkowski, went to the floor and said, absolutely not, you will sink the Medicare bill. And the Pepper Amendment was defeated. It was a good argument. The right argument is that the addition of the long-term care benefit would have sunk Medicare. Thank you very much.
Thank you, Bob. I just want to mention something, your point about putting in restrictions to access to services in regulation. There is, of course, a coverage process.
Yeah.
That's a yes or no kind of a thing. Now, the fact is the coverage process has been completely porous.
Oh, sure.
But that doesn't mean it'll stay that way. So this is an active issue. Anyway, Kavita, please give us your comments.
All right, so I'm going to try not to reinforce. I never thought I would say I would reinforce some of Bob's comments, but without reinforcing too many, let me actually offer a different perspective. And I also agree this was a very valuable study. Aside from its limitations, and I think just Marge mentioned this, I think, at the top of her PowerPoint, not only does this not include MA, but not Part D as well. So the pharmaceutical piece, of which recently many drugs have become kind of more engaged. We've been engaged in a more broad discussion around the inclusion and cost of drugs in Medicare and what that means to beneficiaries. I think those are all important limitations. What I did find fascinating, and I spent time in California, and let me just tell you, all of California is definitely not alike. So there are and I am from deep of the heart of Texas, and there are parts of California that actually are somewhat similar. What I find interesting is that having had a lot of blowback from working in the Obama administration on trying to actually put some of these provisions into Medicare, such as some of the, not even end of life, just some of the counseling decisions and asking for doctors to be able to receive compensation if they did decide to spend a visit to counsel patients, and watching the reverberation that came from largely people who were opposed to health reform, but also in the form that it was, as well as a great deal, if anybody has not forgotten, the town hall meetings in the summer of 2009, where the giant posters all across the country and including in parts of California read, keep the government out of my Medicare. So I do find it kind of fascinating that, 5 years later, there seems to be some amnesia about what seemed to be a national dialogue, yet I think the med chat, this chat kind of format is obviously a lot more detailed and isn't just filled with rhetoric. I do think, so I still practice, and I also thought it was interesting that in many parts of the detailed report, you'll see these themes of let my doctor do what they want, or try not to curb or infringe on what doctors do, which as a policy person in Washington, D.C., is very interesting, because so much of the policy debate is around how we can think about doctors and the decisions they make. So I absolutely agree with Bob. We do not want CMS regulations, and I don't think any administration wants to be in the position to say, here's what we define as high or low value, and here's how we would execute that or ask for that to be done. But I would also argue that the way our current Medicare benefits are set up, doctors are effectively boxed into doing some of this anyway. So not necessarily the low versus high, but decisions around what to offer patients. Even that example of AFib that you gave, there's very much kind of a decision-making process when we find out that a patient might be restricted by just the cost of their Medicare Part B and some of the co-payments, et cetera, as well as Part D payments and the drugs that influence some of the decision-making around what kinds of treatments we offer. So for those who do not think we do any rationing in Medicare, you're wrong. I mean, so I think it's an interesting dynamic to kind of say, here's the regular Medicare program, which really has no restrictions, when that's not really true. I also think that people are not patients when they're doing exercises like this. My experience has always been, though, that when someone becomes a patient or is in the process of receiving care, especially in kind of critical hospital settings, all of this rationale goes out the door. So one of the most complex aspects of Markov models, decision-making, game theory, prisoners' dilemmas, all of these exercises is how to execute changes, given that at points of service, people often do make different decisions. And I'll use one example. I thought this week's release of the Institute of Medicine report around end-of-life care was especially timely, coinciding with Marge, with what your center did. Nothing in that IOM report surprises me, yet again, I don't know how many times all of us have had discussions around decision-making, end-of-life, palliative care, hospice care, and these, it seems like there's a cyclical nature to this, that we have these conversations as a society, yet we fail to take action on them. It does seem like there's a convergence of sorts, because there is a lot more attention being paid to healthcare spending, whether you want to believe the Dartmouth Atlas or listen to Louise Shiner at Brookings and feel like the variation is not exactly what we thought it was, or whether you also want to look at the recent numbers from Medicare and trends in cost and growth and how we're doing, quote, better, and what is that from. All of this is still coming into play now with how we make decisions for an aging population. And I do think that this is a timely conversation. What I do think is very difficult is that nobody's really also, the IOM report did get into it a little bit more, but neither this nor the IOM report really kind of tackled. We can provide coverage, we can think about ways to say we're not paying for ICU stays, But in my experience, the largest barrier is largely behavioral. We don't like to talk about death in this country. And there's no degree of an IOM report, congressional action, presidential conversation, or even a public debate that's going to really do that until we kind of acknowledge that. I have yet to find even the most sophisticated clinicians feel comfortable in facing families and saying, this is really it, and we really can't do more. It's a very difficult conversation to have, and I think that's something that, as you know, I'm not trying to suggest that Marge and your center take this on, but I do think that there's opportunity to learn from this, build on it, and take some of what you've done and actually extend it. Let me also just say something about these kind of low and high value services. There's been an extensive amount of studying to actually define some really low value services. I mean, we should not be doing yearly pap smears on women. I mean, the American College of Obstetrics and Gynecology, USPSTF, a number of bodies have kind of had growing evidence. Yet these are examples of very clear low value services that even without CMS regulations, it's kind of astonishing that we're doing this and still practicing this. And so I do think that, and organizations like the American Board of Internal Medicine Foundation and a lot of specialty societies have actually identified kind of what they would call choosing wisely, decision points around services that should not be done. Another example is yearly EKGs. So there are some very simple, basic, low-value services that may not be, as expensive as treatment for hepatitis C, but certainly when done across an aggregate of a population should not make real dollars and should not be reimbursed. That is absolutely the kinds of things that I think, as Bob was mentioning, when we get dollars to donuts and make real decisions, should be incorporated. And I think private insurers are absolutely thinking about this kind of value-based insurance design. Medicare struggles with it in the traditional fee-for-service. Medicare Advantage, I think the reason there's been such an explosion in growth is because MA offers the ability to not only think about provider networks and choice of these types of services, but some Medicare Advantage plans do incorporate aspects of transportation and these other services that I think some of the participants in the survey identified. So what we have as a country is actually a viable policy option in some forms of Medicare Advantage. Not all of them. I don't want to seem like everything that MA does is kind of, a gold star. But I do think that there's going to have to be this conversation between the traditional and what we're seeing in Part C, and then also bringing in Part D into it. So if I think about the impact to kind of, I mentioned providers a little bit. This report did not touch on providers. I think there were some healthcare professionals in that 810. I noticed that in the report. So I do think it's interesting. I personally would love to see Congress do this exercise because I think it would be a very different result set that you have, but it would be a very important one. I think that patients, if everybody had to put on their societal hat to do this exercise, if we actually had them go through this exercise kind of when they were patients, it would almost be an even more interesting kind of truth-telling moment because that's when you have to make decisions. If it's not just taking a societal perspective, but it's you and your health, and these decisions are going to then be enacted and changed for your personal benefit card in that moment, I do wonder how different decisions would be made. But I do, for policymakers, this is a DC audience, so I want to kind of take some abstractions from this for policymakers. I've already highlighted one, that we should have a more engaged conversation about how to translate some of these findings and also think about the balance between traditional fee-for-service Medicare, Medicare Advantage, and really also think about Part D. There's a very active group of people kind of discussing Part D benefit design and how some of the reforms in that could lend themselves to helping with the longevity of the Medicare program. Despite all the successes of Part D that we're now kind of attributing to the program, we still have more that we could do, especially with the cost growth of drugs. I think the second policy point for taking away is exactly this long-term care discussion. It was the Class Act. I mean, we've seen what a disaster it was from kind of the not just the inception, or at least kind of the lack of thinking behind the fund. And I worked for Senator Kennedy, and he was one of the biggest champions of including this. So I'm not saying this to disdain the notion that we need meaningful long-term care. he, I think, really wanted to have meaningful long-term care for our seniors, actually for all Americans. But I think the way the financing structure and some of the specifics around the Class Act as it was included were horribly problematic, and I think the administration's decision not to have that go forward is absolutely telling that we still don't know what we're doing. And unfortunately, some of the patches, Band-Aids that were put on the Congressional Long-Term Care Commission, and then some of the other things that have been kind of happening over the last year, have in no way provided a path forward for meaningful long-term care. But the bottom line is it's expensive, and it's something that we know we need to do, and we're still struggling on how to do it. And I do think policymakers should actually spend more time in how we can take this forward. The third area is around some of the benefit design restructuring. There are a number of proposals, AEI, Brookings, I mean, every think tank in the city has kind of offered their opinions on how to strengthen the Medicare program. They all have similar themes. Pay more for chronic care coordination in some format, whether that kind of moves people more towards an MA type plan or not, you can be the judge of that. And then the second aspect is really curbing and actually decreasing, not only changing some of the aspects of means testing by salaries, et cetera, but also changing and curbing some of the services provided in order to lengthen the life of the program. So I think we see a lot of that being reinforced here, but we haven't really taken action on it at a congressional level. And then finally, I think I will always be kind of the proponent. We've had a window of opportunity to do meaningful physician payment reform. We could finally have put an end to this nightmarish debate about the sustainable growth rate and the constant distraction that it poses with white coats, doctors wearing white coats coming to the Hill and arguing about it all the time. And yet I'm concerned that because we had kind of a bargain basement price on fixing the SGR, I don't know how long we're going to get that bargain basement price, and I'm concerned that in future years it's going to be more expensive and that we've missed a little bit of a window of opportunity. So from a policy perspective, there are reforms that can help reinforce what I think the societal perspectives brought out in this exercise illustrate that could be done without trying to tackle, taking on exactly what started in 1965. And then I'll kind of finish with a little bit of a different twist. We're heading into a major presidential cycle, and no matter who we think is running or not running, I think there's going to be an important stance that's taken on either how to look like we're improving the Affordable Care Act or changing, getting rid of parts of the Affordable Care Act. So I again think there's a significant kind of window in this upcoming year to introduce some of these concepts. People have maybe forgotten about, I haven't forgotten about 2009's town halls because I had to deal with the aftermath of it, but I think some people obviously want to move on and feel like we need to move on. There was actually a piece by Zeke Emanuel in The Atlantic, it was earlier this week, I think, and it stirred a bit of controversy because, as Zeke usually does stir a bit of controversy, I think the tagline, the article was much more detailed, but the tagline kind of read that, after a certain age, we really shouldn't be offering services to seniors, and that got blown up into both directions by both sides of the aisle or both sides of the spectrum. I think what's unfortunate is that I see that very smart, thoughtful conversations like the one your center led can unfortunately get blown up into exactly that type of rhetoric. So I think it's people like us who have to make sure that we don't let congressional candidates, presidential candidates kind of get distracted by that noise, because there is so much that could be done that would actually improve the program, increase its lifespan, and just be better medicine. And it would be interesting to do this in the Medicaid context, which is a whole other set of issues. And given how many people are now going to be enrolled in Medicaid programs, there's an opportunity for that. Obviously not at a national level for conversation, but certainly I think what you're illustrating is that you can do this within a state. It's actually something that can be somewhat representative of a diverse population. And I think that would be very interesting to tackle some of these other aspects. So I'll stop there. Thank you.
Okay, thanks, Kavita. It is interesting that Zeke's article, he and he's getting close to that age. And so hence, physician, heal thyself. John?
We have something called age discrimination in employment. Now we go age discrimination in health insurance coverage, I guess. So first of all, thank you, Marge, and I applaud the effort, and I think it's very interesting and provocative. And so I'm going to try to be provocative in my responses. So I don't think anyone here should confuse a very careful, deliberative process that took place in California with what would take place here in the Congress politically. Two different worlds, and there's a good reason for that. Bob and Kavita have already touched on a few, but let me just say, first of all, the debate about the future of healthcare should not start with the benefit package. It should start with other things that are probably more basic, such as how to get the incentives right and how we pay for providers. Much more important than changing benefits. It should start with how do we pay for health care and not how do we limit it. And it should start with how do we look at health care from a system-wide perspective, not just at the Medicare program alone, which would be terribly distorting if we did that. So there's a lot of things that a debate about the future of healthcare should include that aren't included and could not have been included in this. Now next year we will have the 50th anniversary of the enactment of Medicare. And it's amazing that what was adopted in 1965 based on the prevailing private health insurance pattern at the time, the Blues and Blue Cross Blue Shield, has survived for 50 years. It's totally outmoded, but it survived. To have a separate hospital program from physician program and drug program, I mean, who would put a health care program together like that today? It doesn't make any sense. Nor does it make any sense to talk about solvency and only look at the hospital side. That's totally artificial and not real. And you know, come on, somebody's going to say we're not going to pay benefits from December 15th to December 30th because the hospital program is over budget? No, it's not real. Social Security solvency is real. Medicare solvency is not a real issue. Healthcare spending is a real issue. Healthcare burden on the economy is a real issue. Are we getting the value for our dollars? Now, I was part of an Institute of Medicine study a couple of years ago that looked at waste in healthcare. And very, very conservatively, we estimated that about 30% of the dollars we spend in healthcare do not produce value. 30%. That's a lot of money. I would suggest that would be the first place to look before we start talking about cutting benefits. There's a huge opportunity to do better. So, and again, that's system-wide. That's not just in Medicare. So let me talk a little bit about some of the specifics of the findings here. I do think when we talk about low value, the question is who determines it. And the reality is that's going to be the physician. And patients are going to listen to the physician, and they're not going to question that judgment. And so unless we get physicians on board with talking and acting on the basis of what's low value and what's not, we're kind of kidding ourselves. We're not going to get at that through insurance design. As both Robert and Kavita said, you know, no one's going to touch that politically. It's only going to happen if we change reimbursement and if we change the culture of medicine so that it's not about do everything possible, no matter how low the odds of benefit. So that's a challenge, and I think the only way to get at it is, again, through reimbursement changes and rewarding value instead of volume. And the key to that is, as Kavita has mentioned, let's deal with the SGR. On end of life, I think it's positive, and maybe it's, well, we all want to feel good about the fact that there was actual consensus, or pretty close to it, in the discussions. If only that could happen here. We all know what has happened here. The phrase death panels occurs to me. And I think that we are going to have to own up to this. But I don't think we're going to do it through the benefit process. I can't imagine that we're actually going to say we're going to stop a benefit at a certain point. And who's projecting how long you have to live and what's futile? So I can't imagine that that's going to be a benefit decision. I think it's going to be a clinical decision, and it probably should be, and maybe one that involves the family, but certainly not one that involves the program. There is, I think, real value in the recognition that we need to cover supportive services. I took a lot of heart from the value that this group put on dental, vision, hearing, transportation. Those are essential. And if we don't have them, we end up paying even more for expensive hospitalizations. That's stupid. And so that would be a move in the right direction. And as we seen in Medicare Advantage and other forms of integrated care, we're starting to see more attention paid there to intervening earlier and hopefully dealing with problems that can be fixed outside of hospitals and prevention. So I think that's all positive. Behavioral health, the most difficult challenge we face by far. And I'm glad that the group favored increased coverage. Again, I think if we are looking at behavioral health, we would see that behavioral health underlies a lot of our acute care expenses, and I'm not sure how, but we need to better understand how to address that in a way that keeps people out of the hospital. And whether or not people favor limited networks or not, this is happening already, and it's going to happen for the most part. I'm not sure you have to require people to do it. The incentives are very strong today. It's much cheaper. We're going to see, I think, accountable care organizations really grow and become standard. And maybe in the island of Manhattan, fee-for-service will continue, but I don't think very many other places will be attractive for fee-for-service unless you're in a rural area or somewhere where you don't have access to a functioning network. But I think for most Americans, this is already underway. A couple of other comments. The future of healthcare, the future of the Medicare program, is all about chronic care. 5% of the population with multiple chronic conditions accounts for 50% of the spending today. We don't do a very good job helping people coordinate that care. That's front and center. That's the big challenge. And so again, with changing provider reimbursement, doing something proactive that helps us deal with chronic conditions is absolutely the first order of business. I'm glad Kavita mentioned Part D and drugs. We have a tsunami of very expensive specialty drugs now about to hit out of the FDA pipeline that are going to change healthcare costs and financing dramatically. Some of these drugs will actually be cures, but most will not. And the question is it worth paying $100,000 a year for the rest of your life for a drug that might extend your life by 6 months or 2 months? What's the trade-off? What's the value equation? We're not going to be able to pay for all this stuff, nor I don't think should we. But it's going to raise some very difficult questions, starting with why are these drugs so expensive? And isn't there a better way? I mean, the rest of the world seems to have figured it out. Isn't there a better way to keep encouraging innovation without paying such a high price? And then I think maybe I'll just conclude by saying that to me, healthcare and the future of healthcare is the big public policy issue domestically. That's the challenge for us. I think benefits can be part of that, but really the toughest questions and the most important questions are not about benefit design. They're about reimbursement. They're about creating systems that keep people healthy and that manage chronic conditions better. They're about keeping drugs affordable. And I think that there's a lot to do, a big agenda there. And so I think benefits will be part of that agenda, but we shouldn't lead with benefits because they're easily distorted. And in a political environment where there's an interest group for every single piece of the Medicare program and every single benefit, changing that is very tough to do because people are easily scared by change when it comes to health care. And you have to go through a kind of deliberative process, as Marge did, to get people comfortable. But that's not going to happen in the world that I'm familiar with politically. We don't have the luxury of that kind of deliberative process. I wish we did, but we don't. Instead, we have people taking out political ads that scare people. So we've got to figure out how to get this done in a way that minimizes the political difficulty of change. And I think benefits can be part of that, but I wouldn't lead with benefits. I'd lead with efforts to address waste, unnecessary spending, unnecessary prices, and the lack of coordination in our system. So thanks for raising all these issues, Marge.
Okay, thanks, John. One of the things about the chat process, which you mentioned in the report, which I think is worth emphasizing. Now, I'm not saying that health insurance is boring, but it is complicated, and so one of the reasons why people were able to, I think, participate in a useful way in this process was also that you didn't give them an infinite number of choices. And that's another little defect of the political process. Not only are they, even when they focus on a specific issue, which is extremely rare, by the way, there are a lot of variations. In Medicare, there are a lot of levers, and it's hard to know when to stop. And then you add to that the layering that that's not what they're thinking about anyway. They're thinking about something else. Well, that's kind of an upbeat thought about politics, isn't it? Marge, would you like to respond to the panel?
If I can do that, and then push the thing. Okay, great. I wanted to quibble with John a little bit about your comment that we shouldn't be starting with benefits. We should be starting with, among other things, dealing with the cost of drugs. Those are benefits, and that's my quibble. So when you're saying the whole emphasis, 4 categories dealt with the concept of low-value care. We didn't call it that in every category, but the message was there for catastrophic, routine, complex, chronic, and final phase. And in fact, it is, as you know, the benefit design, the tier part that really deals with what is it that we are going to cover for you under what circumstances. That's nothing if it's not about how do we control the cost of extraordinarily expensive things. So I don't want the concept of benefit design to be taken too narrowly. The public loves, it's like the categories are benefits, the tiers are benefits design. The money is in the benefits design. It's not in the categories themselves.
Now, can I quibble
Yes.
back?
Yes, you may.
I think the money is in the perverse incentives of fee-for-service.
Okay.
And I think if we dealt with that first, we would be much better positioned to have then a more reasonable debate about benefits. I don't think we should start with benefits.
Okay, and I don't quibble with that. It is that if you dealt with the perverse incentives for fee-for-service, our 30% waste will drop down to 10%. And then you won't have the big dilemma that they have now. I also wanted to respond to the comment that Kavita made about routine care and the importance of prevention and all that. And I wanted to point out one of the observations I didn't have time to earlier. When I said that 4 categories dealt with the concept of low-value care, and one of them was routine care. So the 2 categories that the majority of the people wanted to keep at current was catastrophic and routine, and for very specific reasons. Why were they okay with basically not using evidence-based medicine for those 2, but they weren't willing for complex chronic? Routine is particularly interested, and the main, and it's in the full report, the main reason is we have so drummed into everyone's head that prevention and screening is so important that the more the better. And to try to show them that there's no evidence base for doing colon cancer screening over the age of 85 will simply fall on deaf ears as long as we continue to tell them that more is better. So it was still only 52% that wanted current and 48% that said no, low value is low value even under routine, but in fact more than 50, mainly for that reason that they revere prevention. So we're really stuck with some messaging problems on that one.
Joe, I forgot to say something I want to put out. I am amazed that we had this discussion and no one, including me, referred to the essential benefits package in the Affordable Care Act, where we had this debate. And we had it in a way that results in a standard set of benefits that will influence Medicare as people get used to that and then transition into the Medicare program. Why should we have a whole separate debate about Medicare benefits if we've already had the debate for everybody else? It's, again, my effort to be provocative, but I think if we feel that the standard benefits, the essential benefit package is appropriate, then maybe it's appropriate for Medicare as well.
Well, and that is exactly the point, isn't it? Well, why don't we, do the panelists have any other comments they'd like to make?
Yeah, just want to remind everybody that the preventive benefits in the Affordable Care Act are mandatory for everybody, and there's no cost sharing at all. So there's a profound gap between between the 800 Californians who are ahead of us all and the Affordable Care Act. Just mentioning it, just saying.
All right, great, thanks. All right, so let's have questions from the audience. Let's start with this gentleman here.
I'm Basil Scarless. I've worked and lived abroad in Germany, and I find it interesting to compare the U.S. and German healthcare systems. But my question is directed more at what the panelists all mentioned. You'd get perhaps different results in different geographic locations of this survey. What about the income distribution? Would you get different results for people, say, below $50,000 in annual, for families earning below $50,000 in annual income?
Let me make a quick reference. We did the demographic differences on everything we looked at. I didn't mention it just because I was waiting to see whether anybody else wanted to ask about it. So the differences, and there's also a lot of pre and post survey questions they're really worth looking at in the report, but I'm not going to get into it. I'm going to mainly focus on how they chose the categories differently if they did. So the low income folks, just to give you a picture, for Tier 3 and complex chronic, they didn't want to diss low value care. So the overall average was 11% wanted to keep it at current for complex chronic. Low income were at 20%, not 11%. So you saw the lower the income, the less likely they wanted to give up some of the things we call low value care. Little bit of difference in final phase. I said 3% of the whole group were willing to stay at Tier 3, the current final phase. That was 5% if they were low income. Interestingly, paying more for Medicare, that's where you got to contribute your markers. To contribute, the overall was 15% were not willing to do it. It was 23% for low income. So they clearly wanted to use their markers for more services and not worry about saving it. Those were the only really major categories for low income. Education level and low income was pretty much joined together. So there were some statistically significant differences, but none of them that were huge.
My name is Barbara Dello. I'm a nurse, and usually I get dressed in a business suit and I come with my good manners, and I try and read these very convoluted bills which say things like, in section so-and-so 2.4 2C, change end to because. And I spent the past 6 years of my life doing this because I care about my patients. But today I'm going to talk from my nurse's heart, because I read this study, part of it, and the first page, and I was in tears, and I was livid. So I apologize for that, but I have to tell you, I think the premise is wrong. The premise is that you only have 100 markers. We live in a wealthy society. I drove here down I-95, and I drove on the Baltimore-Washington Parkway. And on I-95, there's all big new overpasses, which cost billions and billions of dollars. And on the Baltimore-Washington Parkway, there's all these beautiful stone facades on the concrete walls. And Washington has been rebuilt. So it's a question of priorities. And we are being sold on this idea that the priority we have to cut dollars on is health care.
Okay, so what's your question?
Oh, my question, okay. Just let me preface my question by saying one thing. I lived I had a teacher from China, and she explained in China, the good of society is considered more valuable than the good of the individual, and individuals can be sacrificed for society. And that's basically what it says in the first page of this study. My question, and I worked with people who, I spent my whole career working with miracle cases.
The question.
And to say
The
low-value
question.
lives is terrible.
The question, please.
Okay, here's my question. It's about what Ms. Patel said, and I wanted to ask Mrs. Ginsburg, or Ms. Ginsburg, if she agrees that often what people say in these end-of-life discussions is quite different than what they decide when they're actually sick and it's about tomorrow.
Make a question out of that.
I'll just say, my experience is as a doctor practicing, so it's truly about just the fact that whether it's end-of-life issues or it's asking for an antibiotic when you're in an office visit, that decisions are often very complicated when you're in an individual context. So, and I think, I don't think the center ever tried to attempt to capture that, because I think what it engaged in was much more from a societal perspective. And I think the context that's probably the most important is that I think all of us who have sat at this table have had to take things from a societal perspective when we're doing policy making. And I think that's where I kind of take away from this is, as John said, how do we make kind of broader policies, whether we're looking at benefit design or incentives? And I think that's the most important take-home message. So the individual is not lost in this. It's how to think about the larger context.
But I will respond to that, because the end-of-life discussion was so interesting, and the one that when you look at all the ways in which we provide medical care, certainly end-of-life is the most personal and the most vital and the most dealing with compassion. So at least in the groups that I facilitated, and if I felt people were coming to their response too quickly without a deeper thought on what this means, I would challenge them and say, are you really prepared to quote, pull the plug on your next door neighbor or your mother or anybody else you know. You're not going to fund this treatment that they feel might be important to them, even though research shows that it's probably not. And most of the time, the response would be, we're not saying they can't get it. We're just saying that we shouldn't be using societal resources to pay for treatment that is so unlikely to be beneficial. So, no, does that mean that they will take that into account when they're faced with that situation at the bedside? Probably not. But at least they've had the chance in this environment to recognize what their decision they're making in this context, what that actually means in real life. And all we can do is report what we see, what we hear, what we do. And I think the bottom line really is very, in this category, very consistent with the Dine in America message, which is, wow, we do this so badly that the general public will say, the only way to get it to stop is don't pay for it. And then we'll stop doing things to people that they actually don't want and don't need. So, anyway.
Well, let me just make a comment, and it relates back to what John said about incentives, financial incentives. And we have a system, we're talking about traditional Medicare, but it's also just largely true. We have a system that rewards providers for exactly doing those things. And in fact, the more expensive, the better. Because the marginal cost of more expensive things is usually not that high. So I mean, this is a general issue. This is a defect in the way we pay. It's a defect in our reliance on fee-for-service, and it's a defect on, frankly, government price setting. I mean, the physician fee schedule is ample evidence that we don't do very well there. So in fact, it just occurs to me, it goes back to something Kavita said, it really is the professional responsibility of the physician, after all. Although I disagree with the theory that patients will not have semi-informed opinions. Whenever a doctor tells me anything, I Google it, and
They usually come to me with everything Googled, so.
yeah, no, exactly, and that'll be
I
true,
agree.
right? And that'll be true nationwide. I mean, younger people are just used to that kind of way to learn, and so there's an element of learning possible, even on clinical matters for the public. But we still need physicians to be, first of all, better informed about their own work, and second of all, better incented to do the sorts of things that make sense, which is not necessarily just save money. Bob.
I think you raised a good question, which is, frankly, at the end of the day, who is the key decision maker in the system? My whole argument, and we didn't get into a healthcare debate here about, what's the best way to do this. But the point that I made about not making a fetish of evidence-based medicine is that I think it is absolutely essential, whatever we do, to make sure that we recognize that there are certain problems that public policy itself cannot solve. And therefore, we must leave ample room for clinical decision-making by medical professionals. And my argument is they make it best when they are doing it in consultation with their patients. That's the only point. But I think you raised a very, very good point. You mentioned China. We do not live in a country that says that the individual is to be sacrificed to the group. That is not the United States, and it should not be the United States. Some people actually may want to make it like that, but it is not. And that point is critical.
Roy Rampler with West Health. Question for Marge. Given politicians' sensitivity to how seniors will vote on things, can you talk a little bit about the age differences and maybe some of the results?
Yes. So the biggest differences were between those under 40 and those over 81. We did have a good span. 81. Everybody else in between, shocking, I know. So in terms of the provider network, the younger folks I'm looking at tier 3, which is what percent wanted to keep with the current, you can have it all. Only 7% went for tier 3 if they were under the age of 40, versus, so that was for younger, versus 17%, which was the average. In terms of the catastrophic care, it's very interesting. That's one where one more marker will get you the Hail Mary pass. It's only one marker. So the average overall was 53%. That was one of the categories that majority wanted to stay with current. Younger folks, that bumped up to 65%. So they were the ones that saw catastrophic, where you're healthy 1 minute, something horrible happens, that they really saw they wanted even a long shot chance of being able to return to normal. They felt more strongly about that than older people. Just looking for meaningful ones. Routine care was interesting, and that was also one extra tier, got you non-evidence-based medicine. So those that picked tier 1, 59% versus the old of 41%. So in other words, the older you were, the more inclined you were to want that extra chance under routine care. Younger people were more sanguine about, we don't need it. So those were sort of some of the major differences between them. Not dramatic differences, but there nonetheless.
But you might also interpret it a slightly different way,
Okay.
which is that people sort of project according to what they, how they feel now and what their circumstances are.
Yes.
So this is a public policy point. It makes the usual argument that you need a sensible transition if you're going to change policy. You can't just wake up tomorrow and say, okay, this is it, which unfortunately we do have a tendency to do. Any other questions? Yes, Bruce.
I wonder if any of your questions either did or could address the issue of how you would like your provider to be compensated for the services they perform. Did you get at that, other than the network issue? Did you get at that at all?
No, we decided there were, as you know, there are so many different hot button issues we could take, and because we had a 3-hour time span and fairly complicated issues, we really had to make some hard decisions about what big issues we were going to take on. The only thing we did at all about compensation, we asked a pre and post question about, in the interest of Medicare's fiscal stability, which of the following would you believe would be reasonable approaches to take? And virtually all of the things we asked them matched up with what they then went on to debate. We asked the same question post to see whether they changed. So we did put in one item there to see whether it would change at all, but the fact that they never talked about it. And one was whether physicians' salaries should be reduced. And they didn't budge. It was very low. Something like 13% thought that that was a viable approach to trying to get a handle on health care. And so the only meaningful conclusion there is if you don't talk about it, their views don't change. Every other category, their view changed quite substantially based on the discussion about, about low-value care, about provider networks, all that. And again, I would urge you to read in the report. So why didn't we talk about physician compensation? We certainly thought about it. I will tell you my opinion based on other times we've asked this question. The public, and also others who have done research on that, public really doesn't want to muck around with what we pay docs. They revere doctors, and they are worried that if you lower what you pay doctors, that you're going to start getting lousy doctors. We have never used that as a deliberative topic. Again, these were all just survey questions, but I think other groups, I think RWJ did a survey about that as well in more depth. And people don't want it to come out of their doctors' hides, and they don't want it to come from the hospitals either. They have that same view. These are their resources that they trust, that they go to deliver the care. If you lower what you pay, you're going to get worse care.
Just one comment on the extending Medicare's life. The Affordable Care Act did extend Medicare's life quite substantially. And the senior population gave that absolutely no credit. In fact, it was perceived as a threat. You're cutting benefits as a way to extend or cutting reimbursements as a way to extend the life of the trust fund. So again, I'm cautious about trying to translate this process into politics. I think they're two different kinds of discussions.
I think we've run out of questions, and so please join me in thanking a panel for a great discussion.